Harrington.
And seconded by Director Harrington. The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to accept the minutes. Aye or nay, Director Harrington?
Aye.
Director Ketting?
Aye.
And Chair Curry?
Aye.
You have 3 yeas and 0 nays.
The ayes have it. The motion carries. Next, I'd like to move on to the report on health plan services, which will be presented by Aaron Galena, who's the Chief Administrative Officer of Health Plan Services. He will review the report and metrics along with some of his staff. Mr. Galena.
Thank you. Let me just pull up the slides here. So we'll start today talking through our usual metrics and then spend a little bit of time on the County Care 10-year anniversary. Before we go into some more detail and data on our quality and health equity areas, and then we'll finish with growth innovation and our annual choice campaign. So just for a little bit of context, I think especially in the quality and the equity section of this report, we're going to go through quite a bit of data today, which I think will help set the stage for our January Managed Care Committee meeting, which we'll plan to then present more on what the 2023 work plan looks like and what a lot of the initiatives will be based on some of the data that we go through today. So I know that's sort of the natural question of when we're going through data to look at what sort of the interventions we want to drive off of that. So that's sort of how we're thinking about laying out these next couple meetings. And with that, we'll jump in. Our membership through October is at 438,000. This month we returned to sort of the typical growth trajectory that we've seen for the past couple years. As you'll remember, we had a couple months of declining enrollment due to some one-time adjustments that were being made by the state for third-party liability and a couple other reasons. This is the market data. This is still through July, which I believe is the last data that you had seen previously as well. So we haven't seen the update just yet for some of the future months, but we're holding at the 32.7 market share percentage. And the rest of the market has remained pretty steady as well for this period. Here's our enrollment versus the overall Medicaid managed care market trend. So County Care is on the left, the overall market's on the right, which you can see we track pretty closely to what the general trend looks like there, with a little bit higher growth than the rest of the market at 7% over the past 12 months versus 4% for the rest of the market. Here's our information compared to our budget as we look to close out our fiscal year. So you can see we continue to exceed our budget as expected, with the public health emergency continuing. As you know, the public health emergency was extended yet again recently, and so the next time frame that it could expire is now January, which puts the earliest date that we could potentially see membership attrition due to redetermination really in the March time frame. So we'll be watching closely if that public health emergency continues to get extended, or if January will be the end date of that. And then on this slide, you can see in October, again, that we've returned to that growth, as I mentioned before, after some couple declines in July and August. In terms of operations metrics and call center and SLAs, you can see generally holding around SLAs here. We are monitoring a negative trend. We've seen a little bit of increase in abandonment rate over the past few months, and then the percent of calls answered in 30 seconds in September has fallen below our target of at least 80%. Call center is, particularly important, and we're really monitoring that closely and working through some corrective action plans. This seems to mainly be related to staffing, the number of staff supporting our call center at the moment. So we'll continue to monitor that and report that back to the board. But I did want to note that that's an area that we're looking at very closely right now. And then claims and encounters acceptance rate continues to be right at the state required metric. This shows our inpatient utilization versus the prior period. So orange bars here are prior period, the blue bars are current period, and then the light blue is our projections forward using authorization data and IBNR estimates from our actuaries. You can see that the blue bars are continuing to come in over the course of this year, really lower than prior year inpatient utilization was. I will note that we are seeing an increase in hospital outpatient utilization in particular versus the prior year. So we're seeing, especially I think, lab, radiology, pathology type services increasing quite a bit year over year. And so that is something that we'll be watching to see if that then is going to lead to an increase in inpatient utilization downstream from some of those services. And I think a lot of that's the area we saw quite a bit of decreased utilization in over the course of the pandemic, especially in late 2020 and on into early 2021. So not necessarily surprising we're seeing some of that rebound this year, but is a trend that we're watching in our experience. This shows our COVID vaccination rates by number of doses. Currently out through the third dose, we will be adding soon a fourth dose look at this as well. And this is also categorized by age demographics of the members. And so you can not surprisingly see that especially the older adult populations have higher vaccination rates and higher booster rates. And then those rates decline pretty much the younger you go in the age categories. In terms of claims payments, we're continuing to sustain around that 30-day mark that we target with some slight fluctuations. And this shows our breakdown of aging by age category, so over 30, 60, and 90 days. And again, you can see, the over 60 and 90 days has continued to be very minimal. And then some fluctuations in that 30 to 60-day category, which is really where a lot of our efforts are focused on currently. As I mentioned, October 26th is the 10th anniversary of County Care. So we're very excited about this milestone and wanted to take the opportunity to recognize our team and our members who, many of whom have been with us for a really long period of time during that 10-year window. So we're very excited about the milestone, and it's a great opportunity for us to look back at the impact that the plan has had over that time period. So as a reminder, in 2012, the plan was begun under an 1115 waiver that CMS approved with an initial goal to enroll 125,000 eligible members. And so that involves, standing up a network and all the other health plan operations that go into that. And we really saw really exceptional, demand as you would expect, expanding a year early for the Affordable Care Act population. So, 68% of County Care's newly covered individuals in the first 6 months received some type of care, and 85% over that initial 12-month period were engaging with care. And of course, we signed up a really significant amount of individuals over that first year. You can see how our membership's grown over time. Now, as you know, up around the 440,000 mark from that first year of around 100,000. So it's really a astonishing look at this and the impact and members that have chosen us over over these years. Here's just some summary of impacts that I think we also had included in a resolution you had approved at the last board meeting, but the number of claims, prescriptions, total appointments, and screenings and immunizations that our members have received over the years. And then here's a highlight of our choice campaigns and how they've changed and evolved over time. And also a nice segue to what Karen Stanzik will talk about later with our 2022-2023 annual choice campaign that's coming up. So with that, I am going to hand this over to Dr. Collins to go through our clinical quality and health equity strategic pillars and spend some time talking through our data. And then, as I mentioned, this will lay the groundwork for our conversation at the July meeting around what our work plans will be in 2023.
Erin, you can advance to the next slide. Thank you, everyone, for joining us today. Just want to highlight, first of all, our quality overview. So the measures that we look at in terms of determining our quality are NCQA, the National Committee for Quality Assurance. That's the health insurance ratings, and we'll go over that. And that's a culmination of not only your accreditation and you being accredited, which is really important, but also your CAP scores and your HEDIS scores, which are right below there. CAPS, and we'll go over this also, is really what our members think of the health plan and the providers within our network. And then HEDIS, which we will review also, are those specific measures that we are aiming to provide for our members in terms of care. Next slide. So when we look at the NCQA ratings currently for the County Care Health Plan, we are at 3.5. We are fully accredited and are rapidly preparing for our next accreditation phase, which will be June of 23. But overall, you'll see on the next slide, that rating has held steady. When we look at 2020, no ratings due to COVID, and everybody was trying to sort out what we would do related to health plan ratings. But for 21 and 22, you can see overall our score has been 3.5. How does that compare to the other MCOs within the area? You can see right below. We continue to be one of the top rated health plans within our area in the state of Illinois, and we hope to continue that. Next slide. The next component that we look at is what we call the consumer assessment of healthcare providers and systems. This is the CAP survey. Like I said earlier, it really is a great mechanism for us to gather feedback from our patients' experience within the health plan and our providers. Yes, Mr. Harrington?
Yeah, I have a question about the previous slide. You indicated the score, but what is the scale? Is the top 3.5 or is it 4?
So it's 5. It's 5 stars.
Okay.
So actually the slide
Okay.
before that shows that it's a 5-star rating. And that is our goal, to be a 5-star health plan. And we work
Okay.
with that. So the CAP score is administered every spring through early summer, and it's split between the children and the adults. And basically, we're going to go through some of those performance measures next. Next slide. So we do know and recognize for 2022, we did see a decrease in our response rates. From 21 to 22, we decreased from about 14% to 12%. We think that really those members that respond overall have either a really good experience or a really bad experience within the health plan. And so we're really looking at what are other mechanisms for us to ensure that our members are filling out the CAP survey when they become available. So things such as every time they call the members services line, we're reminding our member services reps to remind members that they'll get a survey and we want to hear their response. But also as we get closer to the time that the survey goes out, sending text messages as a reminder for our members to fill out that survey. We've noticed that the highest percentage, both for the adult and the child CAP survey, are primarily respondents are female. We're starting to diligently look at equity and race and ethnicity in all of our data. And we can see from here in that center box, about 35% of our respondents are white, about 36% are Black, 7% Asian, 61% are Hispanic and Latino. As we go down to that last graphic, there are some areas that we really identified that we did well in, and definitely some areas for opportunity. If you focus on the colors, 2020 is the gray bar, 2021 is the blue bar, 2022 is the green bar, and you'll see some sort of target areas that are yellow, which are the areas of goal. And so when we look at where we've stood over this last year, we can see that we improved significantly related to customer service. We improved significantly in terms of rating of the health plan. We do and have noticed that there are definitely opportunities in terms of getting needed care and getting that care quickly. And also I would add how well our doctors are communicating, not only with the other providers that are taking care of our members, but also communicating with the patients. I see two hands up. Mr. Harrington, not sure if your hand is a new hand or your old hand.
It's a new hand, but Director Keating was before me.
Okay.
This is just a picky point, but on the respondents box here, something's amiss because it adds up to about 150%.
Are you talking about the 12% and 14%, that box?
The box that says respondents, it's in the middle.
Oh, I see what you mean. Yes. Actually, yeah, totally. Yes, you are correct. So actually, it's probably the Hispanic portion of that box. You'll see in some later slides, we're working diligently to try to ensure that we get all of the race and ethnicity data on our members. That information comes from the state. And what we find is that in most cases, that is the one population that is probably not appropriately accounted for within the data. So you're absolutely correct. And that actually should probably be more like 23%. Not 61%.
Thank you.
Director Harrington, I think you're on mute if you're speaking.
Yeah, my question is with regard to the survey. How's that sent out? Is it sent out electronically? Is it an email? Is it by phone, or is it paper?
Yep, so it's initially sent on paper, and then there's telephonic correspondence. As we do our membership demographics campaign, we don't have a lot of emails. So taking the opportunity to make sure when we have our members on the phone, we get emails because we'd like to send it also via email. And for 2023, we're also going to send via text.
So the results we're seeing in terms of completion is a combination of paper and electronic.
Telephonic.
And
paper and telephonic.
which ones and so which one do you get more of? Do you get more electronic or you get more paper?
I would have to look, but I would imagine we probably get more once we remind them that they have it.
Okay, and that would be by paper.
Correct.
Okay.
So really trying to be innovative because we know not everybody checks their mail or they let their mail lag, and we only have a certain amount of time. We don't commonly have correct numbers. About 23% of our numbers are incorrect. So really we some members we can't get on the phone. So really doing an all media, I think, campaign is really important here so we can get that data.
Yeah, and this is more by observation. People may have observed the same thing. Most of the mail that I get is junk mail. I mean, I don't get much mail, but every once in a while I get something that I really need to open and look at. But most of what I get is solicitations, and I don't pay that much attention to it. And so while mail is still an important form of communication, the people are gravitating more to electronic means of communicating. And you may want to push out, send electronic at the same time you send the paper.
The paper. Agreed. We definitely have to look for other modalities besides the mail and the phone. Next slide. So this is just an aggregation of all of that data that I just talked about, but I do want to take you to the last two bars. So the last two bars are, well, actually, let me, before I go down to the last two bars, the top two gray bars are really benchmarks. So the benchmark for 21, the benchmark for 22. And what they mean by book of business is for these particular ratings, these are really just Medicaid plans. We're not being compared to Medicare. We're not being compared to commercial. So these are the books of business for Medicaid specifically that do this survey. The bottom two segments really show where we do well, which are the faint green. And then where there's areas for opportunity are those pink bars. And none of that is really a surprise to us. We've really focused this year. We started a CAPS work group in 2021 when we saw our 2021 data, really to be intentional for every department to really identify what's their part in this work, because a survey is really everybody's part within the health plan. It's not just the doctors or the clinical people, but it is from the time you get your welcome packet and that initial phone call saying, welcome to County Care. We want our members to always know County Care, but actually be really satisfied with the care they're getting. And so this gives us just an opportunity to look specifically at Medicaid and how we're doing. But just wanted to show that breakout. You can see rating of the health plan, rating of the members' health care and customer service for 2022 were areas where we surpassed the book of business related to Medicaid. Next slide. The next two slides really focus that same exact data, but from the adult perspective. Again, our response rates decreased for adults also, 18% in 21 down to 13%. Again, not as as a big gap related to gender. 54% of our respondents were female versus 45 were male. We also know related to, and this is probably the better demographics, Director Kettering, in terms of our respondents and ethnicity, 28% white, 58% Black, 7% Asian, 22% Hispanic. Same colors mean in terms of the same years, you can see, again, we did very well with customer service for adults, and we increased and from, you can see that 10 percentile up to the 66 percentile, and coordination of care. What does coordination of care mean? That's how well the provider is coordinating all of the care for that member. So is the PCP talking to the ophthalmologist? Is the ophthalmologist talking to the endocrinologist? So doing really, really well with that. Also, you can see when we go over to the second set of graphics to the right, the rating of the specialists. You can see for 21, we didn't even hit the mark. We've improved that to the 33% mark. So really working on everybody knowing the importance of this particular survey. Again, you'll see at the far left, there is indeed for opportunity around getting needed care and getting care quickly, and we'll talk about that. Communication is another component I think everybody is talking about, and really how we're communicating with our members. So are we talking at a language they can understand? Are we using languages that they understand? Are we using terms that they understand? Do we have an access to a language line? So definitely some opportunity there as we're talking to our providers within our network about how they're conversating and communicating with our members. Next slide. Again, same comparison. The top two are the books of business for 21 and 22. And the bottom two are what we as County Care as a health plan did. And again, rating our specialists and customer service, we surpassed the benchmark. And then the other areas were areas where we didn't hit the mark, but are definitely opportunities that we're working on in terms of how we improve. Next slide goes through a series of, what's important. It was an old slide, sorry. I just want to go through a little bit of what we're doing. In addition to our work group around CAPS, when we looked at getting needed care and we looked at getting care quickly, we've increased our urgent care network because we knew that was a really important component also. And so that has now given us almost 100 urgent care centers also within our network that our members have access to, so that they can, some of it's perception, but we want to make sure that even with that perception, they do have access to the needed care they need when they think they need it. The next few slides are going to review our HEDIS measures, and you can go to the next slide. If you look at our HEDIS measures, we've broken them down into categories. The first category is maternal and child health. That is whether it's childhood immunizations, is it prenatal care, is it postnatal care, is it annual dental visits? That's all that what fits in this particular graphic. If you look at the last four colored columns to the right, those are the percentiles. So are you at the 25th percentile? Then you're pink. If you're at the 90th percentile, you're green. If you look at that area that focuses on measurement year 2021 as our final rate, you can see that we did very well in terms of hitting that 75th percentile for postpartum care. And we did very well in terms of hitting that 75th percentile for child and adolescent well visits. There are definitely some opportunities in terms of childhood immunizations, and those are some of the younger immunizations, and really completing that immunization series within the first 30 months of life. And so now we're working with all of our partners to look at what are some best practices. There are some facilities now, because there's some hesitation, I think, still from parents about bringing their kids in, mobile units either outside of clinics or mobile units that are actually going into the community and actually vaccinating students and children where they are. CPS, I'm not sure if this group knows, but CPS had a huge campaign over the summer, not only with COVID, but gave students the opportunity to close some of those gaps around immunizations. We recently did an initiative around creating a maternal and child program, really for us to get at those prenatal and postnatal visits. So postpartum visits are very important in terms of identifying, is there lingering hypertension, is there lingering diabetes, is there depression, but also prenatal we know makes a difference in terms of decreasing preterm deliveries and preterm labor and NICU admissions. So our maternal child health program is in phase 1. What we're doing now is identifying areas where we see that there needs to be work. One of those is really around cultural competence and humility. We're hoping to partner with March of Dimes so that we can provide some additional education to our providers, because we know that you don't learn to be culturally competent overnight. You're not born that way. And so we want to continue to teach our providers how best to communicate with our members. And I'll talk a little bit more about that later. If you focus on the column that says 2021, again in the blue, you'll see we improved from measurement year 20, which is right to the left of that, for dental visits, for postpartum care, for well child visits. So continuing to work on these initiatives. What we've also started to do with all of our HEDIS measure is really to see if we can get down to an ethnicity level and even a zip code level. And we've seen for a lot of our metrics, probably because some of the data is just better in terms of the number we have in the population, that our rates for African Americans are lower than our standard county care rates when we begin to look at ethnic groups. And I'll come back to that in a moment. Next slide. Our next slide really focuses on what our equity pillars are and keeping our adults healthy. And when we look at that, that is not only getting in to see your primary care, because we believe as a health plan, if we can get you in to see your primary care, they will then follow all of those standards of care in terms of breast cancer screening, cervical cancer screening, colon cancer screening, controlling your high blood pressure and diabetes. You can see that for measurement year 21 for these particular measures, for one measure, we did not hit the 25th percentile, and that's one of our initiatives for 22 and will be for 23, really getting our members in to see their PCP. For breast cancer screening, we hit the 25th percentile. We know some of that was really the backlog from the pandemic, but really sending messages out to our members and encouraging our care coordinators to focus on that particular population who needs that screening. And also, I'll talk about our health fair a little bit later. And then cervical cancer screening, we hit the 50th percentile. And if you look at right to the left of those numbers, these have really been stable, 21 and 20 and 21. So really trying to look at new initiatives and new ways that we can educate our members on the importance of these particular screenings. Director Harrington. You're on mute, I think.
I had an observation really for the previous slide. If you go back to the previous slide. Yeah, not that. It's it seems like where we're really doing well and pretty consistent is in the prenatal and postpartum care, which I could see women making sure that they are getting their care, and it's interesting and ironic that the childhood immunization status is not consistent with that. But that tells me there's something going on that we really need to take a look at that. They're very concerned about their postpartum care, but it doesn't seem like immunization status comes up to that same level. And that probably needs some work in.
And some of these are beyond that postpartum period, which is the other factor. So how do we begin to maybe tie in maternal and peds care together so that when potentially mom comes in to get her birth control or change her IUD, we begin to talk about and have conversations around immunizations and the pediatrician be available to give those vaccinations. But you're absolutely right. After that year postpartum, we do definitely see a decline in the immunization rates.
Okay, thank you.
Absolutely. Next slide. You can go to the next slide. The next category is really chronic disease, primarily controlling your blood pressure, all of that diabetes care, so hemoglobin A1C screens, your retinal eye exams, and kidney disease. Again, if you look at that blue bar where we highlight 2021, we did 50 percentile in terms of hemoglobin A1C screens, about 25% in terms of our retinal eye exams, but did not hit the 25th percentile either on controlling blood pressure or kidney disease. This is a really important slide because not only have we identified in our HEDIS metrics around diabetes care and kidney disease, but also in some of the other data that we looked at in terms of where our spend is as a health plan, that we've identified as kidney disease as one of those areas where there's a significant amount of need for our members. And we set out an RFP to begin to focus around kidney care after our pilot and the impact, just the small impact that we made as a health plan, really to begin to identify a vendor that could work with us. Not so much to look at spend around end-stage renal disease, but really to begin to look at how do we identify those members with early renal disease so that we can prohibit them from extending to end-stage renal disease and needing dialysis. And so hopefully over the next few quarters, we'll have some data around how that program is doing and if we're moving the needle really in terms of kidney disease, but that's a huge area for the health plan. What we also see is there's definitely some work around controlling blood pressure, not only for the member, but also in terms of our providers. One of the requirements for this particular measurement, it is really the last measurement of the year and the last measurement in that visit. So at least for Cook County Health, we've started to talk about, are MAs doing blood pressures properly? Are they ensuring that there's a blood pressure before the member leaves the clinic if they had an elevated blood pressure? But blood pressure, diabetes, and kidney disease also will come up when I talk about some of our utilization data. And this is going to be data that we use to inform really how we begin to build our population health program for 23. Director Harrington?
Yes, I just want to point out that all of these are diet and obesity related, and the Cook County Department of Public Health has a food as medicine program, and the degree to which you can incorporate some of the work that they're doing into what you're doing would probably be helpful.
We're going to talk about that. Absolutely agree with you. Director Curry?
Hi, thank you. And you may be looking forward to discuss some of this, but specifically with the renal and some of the kidney programs, are these mainly internal programs you reference? Are we working with external partners, other specialty areas in this regard?
So initially it started out as an internal program when we saw the need. So we did some education, started having our care managers work with our members, began to be diligent at looking at costs and reasons for admissions and readmissions, and thought we needed to take it broader. So we did an RFP, and now we have an external vendor that will help us with this particular segment of our members. So kidney health in general. So there's a pharmacist on that team. There's a nutritionist on that team. In addition to nephrologists on that team, there's a registered nurse, a social worker, and our care managers will be on that team, all providing care for that individual member that has kidney disease.
Thank you.
Absolutely. Next slide. The next and final slide on HEDIS measures is really behavioral health. I think everybody in this group today knows the impact that COVID has had on behavioral health. And it really has highlighted the fact that we don't have enough providers, but that really behavioral health is a significant need, not only for adults, but we're seeing really significant needs within our children. Again, if you look at our 2021 rates, we hit the 75th percentile for antidepressant medication management. So we're screening our members, we're getting them the medication they need 75% of the time. We hit hit the 50th percentile in terms of continuation of that antidepressant medicine. So not only did we identify you and give you medicine, we're continuing to monitor you to ensure that you're getting the medication that you need. In terms of the initiation and engagement for alcohol and dependence treatment, the initiation, we hit the 90th percentile. For engagement and continuation of that engagement is definitely some room for work. We hit the 25th percentile. Our focus for the remainder of the year and probably into 2023 will focus on identification of those members that are hospitalized or enter our ERs and how quickly we get them into follow-up. That is our follow-up and within 7 days and follow-up within 30 days. And you can see for both of those, we did not hit the 25th percent mark, and really focusing our attention to identification now that we have some other identification methods for our transition of care team to really begin to intervene early. We're trying to determine if we can get our care coordinators actually on site at some of our other high volume institutions. But these two, when I come back, I hope we're starting to move the needle on those, because we know that makes a difference. Because if we don't get them, at the point before they're discharged and arrange everything and get them in within those 7 days, we very commonly lose them, not only to care, but to the behavioral health treatment that they need. We also know that for the African-American population, when we look along the ethnicity line, for those two parameters, significantly lower than our other populations. So definitely a lot of work that we'll be doing within this realm for the remainder of the year and next year. Next slide. So this is some of our strategy as we look at quality and opportunities we know. I mentioned a little bit about our urgent care network. We've added Walmart. As you know, they have 2 urgent care centers, one in Austin, one in Chatham. We've added Well Now. We've added CVS Minute Clinic. We've added Physicians Immediate Care. So like I said earlier, that now gives us another 100 sites for our members to go that are citywide that can help us. Related to behavioral health, I don't think we could hire enough behavioral health providers because the need is so high. We're actually looking at a telehealth provider to help us make contact with our patients while they're in the hospital and help us close those 7 and 30-day gaps and get them into care much quicker than we are seeing now. We've enhanced our member rewards. That's just one way, I think, for us to say that you are doing a good job in terms of your health. We've increased our member rewards around where we see our greatest need, that is behavioral health, that is your routine cancer screening. So we want members to get in and get those done. We're also looking at how we can not only help you eliminate some of those barriers with rewards. So instead of just being able to use it for diapers or things around your house, you can now use your rewards for some of the meal planning. And as I said earlier, our behavioral health group will sort of look at what our behavioral health strategy looks like for 2023. I talked about our maternal child program, but I'll come back to that a little later. But I think the most important component here is really the importance of having good data on our members. We need to know where our members are living. We need to know what are their preferences in terms of sexual orientation. We need to know their preferred languages. We need all of that information to better take care of them, and are working with all of our vendors and hopefully a skip tracing entity eventually to really help us get better demographic data on our members. Next slide. As I turn from quality and began to talk about equity, we're required each year to do an annual report. And that annual report takes the whole year of activity and basically says, what did we do and what have we learned and how will that inform what we do next? This is a social risk factor survey that is obtained when we do our initial assessments and screenings for our members. You can see that very first bar talks about help with food and clothing. These are for adults, but we can see, and I really believe the number is significantly higher than this, just based on some of the data that we see within the health plan and ACHN. About 15% of our members say they need help with food and clothing. If you go down a little further, the other area is that we see a significant number of our members, 21%, that actually have BMI over 30. And I'm going to come back to that. Next slide. When we look at our children, again, the highest area of social need continues to be food, clothing, and shelter. So as we look at that, and it's been that way for the last 3 years. And now as we look at that, we're beginning to say, what can we do about that? And how can we now move the needle on these social risk factors? Because we know for our members that are housing insecure, they're not going to worry about their medicine or their PCP visit until they know for sure that they have somewhere safe to live and food to eat. Director Kettering?
Yeah, I'm curious about the variances among the plans.
Yeah.
It's, I gotta say, it looks to me like it has to be some kind of measurement error or categorization error to see that one plan records 59% over BMI over 30, and another plan 0.8%.
Yeah, let's go back one slide. So yep, and you're exactly right. So if we look at ACHN, CCC, and the health plan, which are probably where the greatest variation is, in the midst of this survey, we transitioned from individual systems and multiple systems to one system. So I think some of the data is not being pulled from these systems, which we definitely have to look at. That's why I prefaced it when I said I would imagine that for these two populations, it's significantly higher. So as we look at CMIS, which is our new internal care management system, we're really looking at how we pull that data from our health risk screenings and assessments into our other data. So you're absolutely correct.
Okay.
Yeah. Next slide. And then one more. I won't ask anybody to read this, but as we segued from where the need is to what we know the data says, Director Harrington, you said it, and I'll just echo it. We know that food makes a difference in just about every disease. We know that the power's in the fork and the education of knowing what to eat and how to eat it and how to read labels. So this is just some of the data that has proven, whether we look at mental health, whether we look at hyperlipidemia, whether we look at hypertension, whether we look at diabetes, all the data says if you do better with food and nutrition, then your patient does better. And so this was just some of the guidance as we began to look at development of our food and nutrition plan here at the health plan. Next slide. What we also did as part of our social determinant of health dashboard is really say, you know, where is our greatest need? So we looked at zip codes where we have more than 500 members currently, and then what is their percentage of food insecurity? And if you can see, and I would imagine it's no surprise at all to our group here, that the south and west sides of Chicago are those areas that are most affected. And if we look at just the top 10 zip codes, that's about 80,000 of our members that are food insecure. So we know there's a lot of work to be done around food and nutrition, which is why next slide, we decided to focus on that. We just completed our RFP to partner with a food and nutrition vendor to help us with that. You'll hear more about that as it comes through for board approval, but just some of the opportunities that we're looking at as a plan, looking at medically tailored meals for our maternity population, especially if they have gestational hypertension or diabetes or they're obese. We're looking at post-discharge meals for perhaps those members that have been in the hospital a long time have been decompensated, produce and health food boxes for emergent situations, but really we want to teach sustainability. So they have access to nutritionists. They'll have access to cooking classes. They'll have access to apply for SNAP benefits if they have not, and really taking the member through the entire process. So I can give you a box, but if I don't ever teach you what to do with the food that's in that box, or how do I make something that you've never had taste good and be culturally sensitive, you probably will never use those. So more to come on that, and I'll take Director Harrington and then Director Kettering.
Yeah, one of the often overlooked strategies around obesity prevention is breastfeeding, and we operate hospitals, and we are seeing patients prenatal visits, and if we're not emphasizing breastfeeding, that is one tool that we might want to accelerate in terms of obesity prevention.
Yep, that's in our maternal child program. I think we have one slide on that, but I totally agree.
Yeah, this is something you sort of touched on. I just want to underline it again, that so many of these things are oriented around the food himself, but what's got to really happen here is the interaction with the client, because if you're going to move someone from a BMI over 30 or even somewhere, you know, in the high 20s, this is going to be a long process and requires certain degree of exercise, change in your diet, and these things we know all of the research about this tells us this is really, really, really hard, and we just shouldn't fool ourselves about. And I think there's a real question that you folks are going to have to face, and that is whether you're going to focus your resources on doing a sufficiently intense program to make a real difference for a smaller number of people, or whether you're going to do something that's spread out across the entire population, but probably won't have much impact, because these are unbelievably hard problems.
Yep, I would totally agree with you. I think we're going to take a two-pronged approach. So I definitely think that we've sort of honed in on a particular population that all of the data shows is probably most beneficial. So if you take that population that has high blood pressure, diabetes, and obesity, so when you look at impact, that's probably a population that you can impact from a variety of mechanisms. The other part of that is you're absolutely correct. We can't feed just say 380,000. We can't feed 380,000 members. We don't have enough money or resources. But can we get them on our platform and talking with our dietitian and teaching them how to cook and how to make healthy options within the options that they have? So I think I think focusing on that really intentional group, absolutely. But for the other members, I really think there is a benefit to them having that conversation and learning that process in terms of where they live and what they do in terms of eating and nutrition. So I would say both.
Yeah.
But yes, the data that our vendor has around high blood pressure, diabetes, obesity, and sustained weight loss and hyperlipidemia is pretty impressive. So I'm hoping that with our smaller group, targeted group, we see those same results, if not similar, very close. It would be a really positive impact. Go ahead.
And
You can say something.
yeah, and particularly getting to kids before they wind up in a situation. And someone presented numbers recently, and the exact numbers are gone, but I was simply appalled by the amount of type 2 diabetes and overweight among our pediatric population. We really, if we're providing care, we've really got to stop that before they get to be adults.
Absolutely. Not phase one, but we definitely have had some conversations about how we begin to work with our partners at CPS, exactly for that reason. We're seeing, 5, 6, 7-year-olds that are developing type 2 diabetes. And we know that will continue into adulthood. So we really have to look at some prevention measures for our pediatric population also. So a really excited program. I'm really excited about it.
I assume there's a natural connection with the public health arm of this too. So
yeah. So just going more into equity, that was sort of the preface to it. Next slide. We're happy to report from our investment in the flexible housing pool. As a reminder, we invested $5 million from our reinvestment funds into the flexible housing pool in order to house 67 of our members for 3 years, providing tenancy supports. We've housed 53 of those members, 39 of which have at least 6 months within the flexible housing pool, and we're beginning to look at our data. You can see the vast majority of our participants are female. We go through all of the age ranges from the 20s to the 60s. Our largest percentage in terms of race are Black. We've seen our criteria really focused on those members with families, those members with severe mental illness and or substance use disorder. And you can see that our biggest component in our flexible housing pool cohort are those members that have both mental health and substance use disorder, no surprise there. And then we wanted to take a look at our impact on chronic conditions. And so when we look at that breakdown, about 50% of that population has hypertension. So as we continue to collect that data, we've seen preliminary, and again, I think it's too early to get excited within that 3 to 6 month of data, that we are seeing some impact in terms of hospital cost. But I think it's too early to get excited. But just some preliminary data I wanted to show for the board. Next slide. So as I close out, what we, as part of our annual report, again, we looked at our utilization statistics. And I use these to really begin to look at, as we prepare for our population health program and what it means, where are those areas that we need to focus. If we look at our 5 top diagnoses, we can see that hypertension, chronic kidney disease, and diabetes in our African Americans hit that top 5. For Caucasians, we can see diabetes overlaps there. And for where we don't have some race information, it's a smattering of everything. We do know from a lot of data that response rates to different medications for the African American population may be different. So as we begin to look at population health and food and nutrition and exercise, what other kind of measures can we begin to look at from a population basis for our members that have those 3 particular diseases? And I'll stop for a second. Director Kettering?
Sorry to keep interrupting. But,
no, it's fine.
I'm a little concerned, and I don't know what to do about this when I see a slide like this where we compare black to white, but white includes presumably a substantial portion of Hispanic, and it gets us into a whole mess about, is race a real biological construct? Probably not. If we're talking about cultural constructs, how can we ignore or not think about whether the Hispanic culture is a contributor here or not? I mean, it's just, and I know, I don't know the answer. All I know is that this raises a lot of questions when we divide the data this way.
Yep, so it goes back to the data that we receive. So again, the Hispanic population would probably be in the race not provided, where we do have our members that denote Hispanic, Latinx, they're put in that category, but there's a whole consensus, as you can see from the numbers in that particular area, where we have no race listed at all. So I don't have any way to prove it, but I would say, just looking at the data, that the vast majority of the Hispanic population is more so in race not provided than the Caucasian and white population.
Yeah, one of the challenges, just to add or build off of, Hispanic and Latinx are ethnicity, they're not race.
Right.
I mean, you only have certain categories or certain,
I get it. I mean, I understand the problem. The question is, when we put out data in public, how do we think about how other people look at this when it begs an obvious question? And I understand the problem clearly.
Yeah, no, I agree with you. I think that's why we're taking on trying to get some of this information as the health plan, as opposed to it coming from HFS, because we just simply don't get it. Next slide is sort of the outpatient, same, you'll see the same caveats here in terms of how race is depicted. But again, I just really want to highlight what we see overall is the same diseases we're seeing in terms of our inpatient and outpatient settings. We're seeing a lot of members being admitted for complications related to their grafts or sepsis related to their grafts. So as we begin to hone in on those diseases, you can see that there's a recurring theme of hypertension, chronic kidney disease, and diabetes, which is not surprising. But what do we do as a health plan? How do we begin to look at that population in totality? So that's what we're thinking through. We have programming for diabetes, we have programming for kidney disease, we have programming for hypertension, but those little programs are not going to move the needle in terms of the extensive population that we have and the effects that we're seeing from these diseases. So that's really where, as we begin to talk about 23, where our focus will be. What will be the population health focus for the health plan? And so just to provide a little bit, as we're really trying to hone in on our geography and our data, I'm just going to go really to the bottom area when we talk about race and ethnicity. We have laid down and sort of looked at, again, our highest percentage being African American or Black. I think that's because that's the data we have for our moderate risk members and also our ACA members. So as we begin to get that demographic data, I think you'll be able to see really more of what our real population looks like. And I'll end with, we do know about 80% of our population lives in disproportionately affected areas. So when we begin to look at zip codes, how do we get down to the zip code level? Also, when we talk about equity and population health, because I don't think we can do it just, as broad categories. We're actually going to have to get into the community and have our case managers and community health workers working within the community to build trust and actually help our members get the care that they need. Next slide. We talked a little bit about maternal child health in terms of our implicit bias training. I'm happy to report we started in September with our community health workers doing outreach. Just within that month with 4 community health workers, we were able to successfully reach 238 of our pregnant members and really begin to educate them on the importance of their prenatal care, on the importance of breastfeeding once they deliver, on the importance of postpartum care. And we're working with some of our FQs really that do prenatal care as one of our incentives. We do diaper bags. We have member rewards around diapers and sleep kits. And we have a Brighter Beginnings program, which is basically a wraparound program from preconception to post-delivery. And really beginning to use some of those resources, not only to outreach our members, but also to educate them. And we are hoping that some of these initiatives begin to help us continue to move the needle on maternal child health, but really make an impact in terms of maternal mortality and morbidity and infant mortality. If we can get them into care, we know all the literature says they'll do better postnatally, and that's what we hope to see for our members. Next slide. And I think this is the last slide, and I'll end here. We had our second health fair for the health plan on Saturday at Provident. If you look, this is sort of what we do as we're planning any particular project. So if you look at the top left, we looked at what are the measures for that group of members that goes to that facility. You'll see the only measure that met either the 25th through the 90th percentile was breast cancer screening. The next thing we said is when we look at these particular measures, how many members within a certain radius can we touch? So we looked at 2 miles to greater than 4 miles. We decided to focus on 2 miles and 2 to 4 miles. And you'll see just with those, that close radius to Provident, we had almost 3,000 members that had deficits in terms of the care they needed, whether it was seeing their primary care doctor, whether it was getting their blood pressure checked, their breast cancer screening, or cervical cancer screening. We then said, if you look at the bottom right column, those are all the members that we outreach to in terms of closing gaps. So if you can imagine, if we had the perfect day and we could have gotten all 4,000 members in, that would have been great. I think we had at the end of the day, actually 109 members register. We had a significant number of those members actually show up and actually complete their mammograms and pap smears on site. So again, a very small approach to closing gaps, but a program that I think is very beneficial because we know there are members who work during the week. We don't have the most conducive hours, most clinics, to getting them in. And so they really like coming in on the Saturdays, and they were able to close those gaps. I should have the next time we present the closing numbers of the actual numbers of measures we closed out. Our goal was to do 3 of these for 2022. It only happened that we did 1, but we actually are starting to plan. This was primarily for women, starting to talk about what a men's health fair would look like at Provident in April. So continuing to work with our Cook County and ACHM partners to really figure out how we get into the community and do more work. Next slide, and I think that may be the last slide. Yes, and happy to take any questions if there are any others. Thank you.
Thank you, Dr. Collins. Good morning, everybody. Karen Stancic, Chief Communications and Marketing Officer for the health system and the health plan. I apologize for the grainy camera, but I'll try to stay on if it doesn't go dark. What I want to go through today is the 2022-23 Choice campaign. The campaign will be in market later this week. And then, as it always does, you'll see a timeline. We go heavy in the winter months and we taper off a little bit. So Aaron, next slide, please, Aaron, actually go to. Aaron showed you this slide, just a a refresher of how the campaigns have evolved over time and the messaging that has been effective as we've moved forward. Next slide. This slide simply shows you some of the creative assets from the campaign that just came out of market in the spring, and a number of the awards that we won. The Astra and the Healthcare Ed Awards are both national awards, and the Pinnacle Award is a state award. Next slide. Just a review of the metrics from last year's campaign, 179 million campaign impressions. We'll talk a little bit more about this in detail as we get into the 22-23 campaign. Aaron, you can jump 2 slides. Thank you. So just a reminder that we start all of our campaigns out with focus groups. This year we did 7 focus groups in August in English and Spanish. You'll see that we did 2 groups for our legacy members, 2 groups of at-risks, and 3 groups of members of alternative plans. I won't read all of these, but I think a couple takeaways for us. This year we saw a little bit more brand recognition and positive opinions from non-members. We think that that's, in line with the plan is growing. We've stayed in market, and the reputation of the plan is really good. You'll see in the creative that respondents prefer visuals that showcase the plan benefits and have diverse, colorful imagery. Next slide. With this one, I'm going to start at the bottom and remind everybody that our audience is our historical Medicaid zip codes. So these are both zip codes where we have a high density of members, and there's a high density of members in other plans. You'll see opportunities. So that's that big table at the top there. And then those 2 smaller tables are opportunity zip codes that we're seeing in the suburbs and other areas of the city, mainly as the result of either growth in Medicaid as a result of the pandemic or growth in our membership in those zip codes. So the strategy is always around retaining, recruiting, reminding people about the brand, and reinforcing the brand promises. And so we do that in a number of ways, primarily around talking with people about the plan features, and in network expansion. We've got an expanding network of providers and pharmacies and urgent care centers and stuff like that. So you'll see how we've executed this on the next couple slides. So I'm pleased to show you the creative for the campaign that will go into market this week. Digitally, it'll go into market this week. You'll see a billboard and a bus shelter here. Again, you'll recall that the focus groups like color, they like the benefits being clearly visible. So we're really, really pleased with the creative execution this year. The next slide shows you a few more of the assets, and in the appendix, there are dozens and dozens more creative applications that you can look at. Next slide, Aaron. This shows you our media buy and our timeline. So we're looking at a $1.5 million media buy. Again, we start this week in market. You'll see heavy saturation in November and December, a little heavier in January, and then we begin to taper off. You'll recall that the majority of members are in market, getting their letters and in their choice period during this time. Actually, Aaron, can you go back for a minute? The transit, those 3 bottom buckets, transit, out of home, and broadcast and streaming, pleased to report all 3 of those go straight through Meeby Weeby, a minority business owner. Next slide. This is a breakdown of how we will spend some of that out of home money. So you'll see CTA and PACE. The gray and maroon dots are historic zip codes, and you'll see the green and gold represent those opportunity zip codes that we talked about. A lot of information on the right if you've got any questions about how we're executing that. Next slide is Metro. Again, same kind of philosophy. So I won't spend any time on this one. Next slide. Billboards, same thing, right? So you'll see the black dots are your historic billboard are your historic zip codes, and your green and teal, or your teal ones are your opportunity zip codes. And then we've got a couple digital highway boards that we've been able to secure for this year. Next slide. Grocery stores, city store boards, and wall art. Again, you'll see the breakdown between historic and opportunity zip codes. Think about, when you think about the grocery locations, think about transaction counters, right? The digital screens are at the counters. Your 150 city store board locations, think about currency exchanges, barber shops, stuff like that. And then these two wall art locations, I don't have those locations yet. We're reviewing the available inventory now with the media buyer. Next slide. This is our broadcasting and streaming plan. Nothing out of the ordinary here. You'll recall that we've had very, very good results with Hispanic video, and Canela TV is that Hispanic streaming service. But we expect these broadcast and streaming spots to go into market middle of November. Next slide. We continue to see really good success in our digital strategy. You'll recall that we're able to double down on digital, right? So if we see that an ad's not performing, we can pull it and replace it quickly with an ad that does perform well. I will not bore you with the details of this chart, other than to note that we are adding Twitter and TikTok this year, as well as piloting an email display ad strategy. Next slide simply shows you estimated campaign metrics at this point. So we're looking at about 175 million impressions. And that is all I have. The appendix again includes dozens and dozens of creative treatments, as well as a glossary of some of the terms in the event that you're interested. At that point, I can open it up for questions. Great. Thanks, Erin.
Are there any questions to Karen?
It's not a question, but I love the visuals.
Thank you, Director Kenning. Yeah, we're really excited about them. I think I've said to the board in the past that, you know, we look at what we're going to show the focus groups ahead of time, and oftentimes, most of the time, we do not select the same creative that the focus groups end up selecting. But this year was a kind of a winner all around. Thank you.
If there are no questions, I believe that Director Curry is no longer here. And so he's asked me to conclude the meeting. And if there are no questions, we can adjourn the meeting. There's no motion required to adjourn the meeting, so we can adjourn the meeting. I want to thank everyone for their participation, and I'll see you sometime in the future. Take care.
Thank you.
Thank you.
Thank you.